Yeah, and I mean, I guess the question. I mean, I think what if you want to talk about what comes out of this, I think that's a great question, and I think that maybe the challenge should be that we need to be asking questions and asking the very simple question of why not? Why does this have to change? Um, why is it that all of a sudden, as you said, the lab can turn around and get you results back in much faster time? What happened? The machine didn't get any faster. How did things happen? How did people come down to the ER? I mean, I think the question has to be, so we keep using this term, the new normal. Well, if this is the new normal and there are good things that come out of this, and those can be the new normal, why shouldn't they continue to be normal? Um, so I think it's a challenge to the leaders to be able to have these conversations when the dust settles a little bit, to say, why can't we take some of the things that we've done? Why can't we have all of a sudden we have these, incredibly flexible ICUs, and we start moving people here and moving people there? Well, when bad things happen next year with influenza, why can't we do that again? Or whenever the next whatever the next thing that comes down the pike is, why can't we do it again? So I think it's a great question, and I think it's something we probably should keep on the front of our kind of on the front tip of our tongues. And the question is probably, why not? Why do we have to go back to the old ways? Because that's what, as Paul said, that's what happened. A lot of stuff didn't. I mean, everybody was nice. Everybody was so nice until about October 5th, after 9/11, and then it just went back to normal. It just went back to New York City. For 3 weeks, it was lovely. It was
I remember
Everybody was great.
on the day of 9/11, I remember mobilizing the hospital to prepare for multiple casualties, multiple injuries. We emptied the hospital. We just about cleared all the medicine and surgery beds. Um, and, the hospital was ready to receive many, many patients. And you wonder, how did they do that? Why were they able to do that on 9/11? And you've never seen that happen any other time. And just as an example that you guys would be familiar with, I understand they just opened 5 South for medical admissions. What is that? 5 South has been basically closed ever since, my late years there. So we're talking, 6, 7, 8 years. 5 South has been closed, and you guys are suffering by having patients, stacked up in the ER waiting for admission, and there are empty beds up on 5 South doing nothing. What is that all about?
Yeah, I think that's the question. What's going to be normal when this is all over? And maybe that could be the valuable take home lessons, that there are some good things out of this that we can fix. We can make them our new normal, maybe, and that would be brilliant if we could do that. It would be absolutely lovely. It would make it so much better. I think we're seeing a lot of good stuff come out of it.
I also think right now the wallet sort of opens up. No one wants to look like the bad person that wasn't opening up all the units, doing as much as they can to expand their capacity. That worrying about looking well to everybody else will drop off, unfortunately.
Good point. It's a good point.
Fundamentally, the reason why it's so hard to change anything is because of the political structure of hospitals. In general, hospitals are confederations of departments: the surgery department, the medicine department, the OBGYN department, etc. And being confederations instead of centralized governments, there's nobody that can make decisions when, 2 or more departments have a stake in the outcome. And if they do have a stake in the outcome, what you see most commonly is that those departments come to loggerheads and nothing changes and nothing happens. And, unless something like 9/11 or the coronavirus pandemic come along to change the system.
That's sadly true. That has always been the politics of hospitals. I'm at our place. We've seen something different. We kind of it was I'm so it can get done, and we've done it, over the last 4 weeks. So we have a chief operating officer at our place who's that Kate's not that, she's been there for about a year and a half. The chief operating officer who used to be the chair of EM down at Grady. And when we went into this thing 4.5, 5, 6 weeks ago, it kind of was decided from the top down that Kate was going to run the hospital. And that's what she's done. And it's amazing what happens when she's given unlimited power, and just allowed to make decisions differently from the way they're normally done, as Paul said, which is based on which department wields the most power, which department wields the greatest income, who's the biggest proceduralist, and whose chair has been there the longest. Those things all got broken down. So it's been interesting for me to watch for the last 4 or 5 weeks. They're gone. The medicine clinic, interestingly enough, is now open till 11 o'clock at night. What the hell? Why couldn't that be before? We're shunting people out left, right, and center, and the chairs are going to these meetings, and the answer is this isn't a dialogue, this is a monologue, and it's changed. So it can happen, but I got a feeling that once this is over, that level of power is going to be quickly taken away.
So let me ask you guys another sort of question. Just having been through, the difficulties and the uncertainty of the AIDS epidemic. I think we were all involved in the 9/11 response and Hurricane Sandy response. What do you suggest to us, just personally, to stay well, to keep a good mindset, and to not have this kind of haunt us as we go, 3, 4, 5 weeks from now, and even 3, 4, 5 years from now?
I mean, that's the conundrum, right? That's the whole idea of resilience and purposeful practice and well-being and, burnout. I mean, those are the questions that everybody's asking. I think we're getting a little bit of understanding, but I don't think we're there. I don't think first of all, I don't think there's a one size fits all. And having been really involved on a national level at the ACGME, I don't see there being, an antidote that everybody can take and make them the happy-go-lucky, carefree physician who loves doing what they're doing and feels totally, absolutely fulfilled. It's totally, absolutely individual. And not only is it individual, but I think it's cyclical, and what works for you in September may not work in January. I don't know. I think the one thing that you have to do is, I of all the things you do, is I think you have to be a little selfish. And I think you have to be, when they talk about mindfulness, I think you have to be mindful of what makes you happy. And you have to be thoughtful about it. And you have to be willing to hold back a little bit to make sure that, if you're not happy and you're not well, how can you be a real person and help make your patients well? So I don't know the answer, Mike. I mean, I just do know that it's something that, you shouldn't, because we're in the middle of a cluster right now, say, okay, I'm going to just forget about it, because that'll come back to bite you in the ass. You need to take care of yourself before you can take care of others. And when you're going through this, especially for residents who've never seen anything like this before, it is emotionally taxing. I mean, I don't know. I was talking to somebody the other day, and I mean, so started in '74 as an EMT in Harlem, as a medic in '77. I mean, I've seen 5 plane crashes, both World Trade Centers, every infectious disease known to mankind. I've been in Katrina. I've been in Puerto Rico. I've seen them. So I mean, I have a certain level of I don't know what you want to call it, but I can understand that hopefully at the end of the day, this is going to end. But if you haven't been through this and you don't have that level of perspective, it can be consuming. So whatever else you do, especially as you're new in your career, you've got to stop and ask yourself every day, how am I? You got to look in the mirror, ask yourself that question, and wait for the answer. And you're going to have to try multiple things to get to hopefully make yourself feel better. But you can't ignore it and just say, well, we're in the middle of the worst thing I've ever seen in my career, and I'm going to just go at it, every day, and I'm going to think about it, because that will not turn out well. And I can promise you.
For what it's worth, and this may be totally obvious, silly, but the first and foremost thing that you need to do while you're a resident, do the best you can to learn as much as you can as a doctor. Doctors with a clinical prowess can accomplish so much more than doctors who are struggling. And so this is the time to learn, and most learning, in my opinion, is done by teaching. So teaching your junior residents, about whatever they need to know. I learned more as a first year attending than I did in my entire residency, both years of it. Things were different when I was here in 1979. We had a PGY 2-3 program. Get your internship elsewhere, and you come to Jacobi and train for 2 years in emergency medicine, and you graduate as a PG3. And interestingly, back in those days, about 50% of our graduates up until the late 1980s were dual trained in emergency medicine and internal medicine. But what I learned later in life was that I could function a lot better politically in the hospital if I was able to engage in conversation that involved clinical intelligence, clinical prowess, and it made a big difference. And in fact, in your daily life as a resident, you probably come up multiple times with the need to justify your position to admit a patient. And that requires learning and education. And I'm sure you all recognize that situation because we all have to go through it. And it kind of requires two characteristics that are valuable to EN docs. One is their clinical prowess, but the other is bravery, courage. You guys are all showing your courage now, I'll tell you. Everybody on the outside can definitely see that. Not easy.
Just take care of yourselves, please, whatever you do. I mean, I program director for 29 years, and it used to make people crazy, but I said at the end of a shift or before you came into a shift, I had a choice between you reading a chapter or reading something or going out for a run or going to go dancing or go to yoga or whatever it is that makes you feel good. I would always opt for that because it's, you just have to be, as Paul said, clinical prowess is incredibly important, and it will buy you tremendous, tremendous respect within the institution. But you got to have a brain that's open and ready and is receptive and is in good shape to be able to input that information. So that balance between making you feel good will make you a much better doctor because you'll be ready to go in and learn, and you'll be at the bedside, and you'll be hopefully. I think Paul's point, which is probably bears repeating. If you want to be great and you want to be a great doctor, you ought to spend a lot of time thinking about teaching. Because whether you're teaching it to a medic or a respiratory therapist or a nurse or an intern or a resident, every time you talk about something that somebody else doesn't know, or more importantly, you may find somebody who knows more than you do, it increases the data bank. But like I said, you got to take care of yourself. If you're not taking care of yourself, then you're not going to be able to. You'll be great, but very quickly your flame will start to go out. And you're going to hate emergency medicine. And I would hope my hope for everybody I've ever trained was that they would never ever come to hate emergency medicine. It's still the coolest job in the world.
It is very cool. It's never boring.
On so many different levels.
Yeah. Every patient always boils down to a problem to be solved within a short amount of time. What everyone represents. I couldn't hear that.